It's a pleasure and an honor to participate in this. Thank you, Imad, for organizing it. And of course, this is a Majid Sami legacy. My disclosures are irrelevant. I don't need to repeat what has been said about Dr. Sami, but I want you to watch the elegance of his hands, of his fingers. And this is really, what can we say about his surgical genius? I can summarize a few points. I think unimitable strategic simplicity, ergonomically optimized dexterity, supreme confidence, conviction, and courage, precision in thinking and executing, unquenchable curiosity and creativity, and many other things that I think fit very well with the topic that I chose today, which is Brainstem Cavernoma. And by the way, Majid, happy belated birthday. You celebrated your birthday 11 days ago on June 19. So very privileged to be part of this today. Take you back to a paper that Dr. Sami has published in 2001 on surgical management of brainstem cavernomas. I refer you to that experience of 36 cases at the time. So what I will talk about today is some anatomy, surgical principles, and case examples of brainstem cavernomas. There are many young people, I hope, in the audience, so I want to remind them what the pure anatomy is of the brainstem, classically divided into the segments, diencephalon, mesencephalon, the pons, the medulla, and some cross-sections rostrally and caudally of these, the medulla, pons, and midbrain, will show you what lives there. Very quickly, just look at the colors of the important structures going through rostral midbrain, caudal midbrain. The pons, you can see that the pons is a bit more forgiving because there is more so-called safe entry zones. This is a caudal pons. This is a rostral medulla, tough area, very dense with important structures. This is a caudal medulla. When you talk, this was pure anatomy. When you talk about surgical anatomy, we have to remember and always give credit to Albino Bricolo for his original work and this concept of risky areas, which you can see on the left, and the relatively safe entry zones you can see on the right. And all the subsequent work really is an adaptation of what Albino Bricolo has done, particularly with respect to gliomas of the brainstem. A more recent paper in green would be considered safe entry zones. I'm going to tell you in a second why that is a very confusing concept. But for example, at the anterior aspect of the midbrain, the intercollicular posteriorly, laterally at the lateral mesencephalic sulcus. What I personally don't consider safe zones that have been said to be safe zones in the midline of the pons, behind the basilar, or between the MLFs posteriorly, that's a very dangerous area. However, the suprafacial and infrafacial entry zones are good in green, and my favorite are the peritrigeminal entry zones at the lateral aspect of the pons. In the medulla, around the olive is your best shot usually, sometimes a dorsal midline myelotomy, but not anteriorly between the pyramids. So here I summarized for you what could be considered all the possible safe entry zones in the midbrain, pons, and medulla. Now, on top of that, of course, you have to add all the surgical approaches that get you there. And here are, this is a selection of the various approaches we can consider. The next 2 or 3 slides, I think, I consider the most important parts of the talk. What are the goals? What are the strategies? And what are the tactics when you want to remove a brainstem cavernoma. The goals is how you conceptually reason through it. The strategy is how you plan analytically, and the tactics is the actual execution of your surgery. So what I'd like to do is to summarize in this table what I consider the 4 steps for each of the goals, the strategy, and the tactics. I don't think I have the time to read the entire slide, but it's just a concept. How do you get there? How do you find the lesion? How do you leave no trace? And how do you resect it completely? Same thing for strategies. You need to know surface geometry, depth geometry, optimal intraaxial neural path, and your microsurgical ergonomics that Professor Sami is such a master of. And of course, the tactics. How do you save, I'm not going to read the whole thing. How do you save the DVA, evacuate the hematoma, avoiding corner it, many, many little details I wish I had the time to go over, but I don't. Here is, I would like to summarize for you what I have certainly made mistakes in the past and how you learn from them. And I've summarized what I think are the most common mistakes with brainstem cavernomas. Number 1, not knowing when not to operate, meaning inappropriately aggressive or inappropriately conservative. Next thing, anatomy does not mean pathology. This concept of safe entry zone is totally meaningless when there is a lesion that distorts the anatomy. Favorable geometry does not mean favorable physiology. For example, this so-called 2-point method of choosing your surgical approach, well, it doesn't work very well for the floor of the 4th ventricle. As you can see in the depiction there, you don't want to go through the floor of the 4th ventricle to get this lesion. It is sometimes better to go through a so-called longer path as long as you're avoiding important structures. So the 2-point method is a useful starting point for you to start thinking what approach to use, but you have to modify it. So thinking of this table I just showed you, step 1 to step 4, if you do suboptimal execution of the first 2 steps, then you will have suboptimal execution of step 3 and 4. People talk about the mulberry appearance of cavernoma. I like to think of it as a red cauliflower, like the picture you see. Why is that? Because it is very easy to miss a piece of the cauliflower if you're not careful. And it's important because it's not a smooth lesion to grab and look for every possible piece. Another lesson I learned, small veins draining the cavernoma into the main DVA should be resected. I want to be very clear. I am not saying remove the DVA. I'm saying remove the small vein. There's always a small vein that drains the cavernoma into a main DVA. Save the DVA, but take the vein. Otherwise, you'll have recurrences. Radiosurgery has no role, absolutely no role in cavernoma. I don't have time to go over the literature, but even our friends in Sweden agree with that concept. So, surgical approaches, many publications have been done where you choose an approach based on the target and the other way around. This is a list, a partial listing of all the possible surgical approaches to the brainstem. Spetzler at the time certainly had the largest experience of close to 400, but even in his hands, look at the morbidity, new permanent post-op deficits, 35%, resolution of all pre-op symptoms, 52%, new deficits, 53%. A meta-analysis of some of the world literature of more than 2,000 cases gives a very similar summary of results. It is clearly not an easy surgery. The main thing is decision-making and executing properly based on those 4 steps I think I mentioned earlier. So we owe Roten an immense debt of gratitude for anatomy. So I'm going to use his anatomy to tell you how I would approach different lesions. These are all dissections from Roten. So for this area in the mesencephalon, I think a pterinal, sometimes a cranio-orbital approach might be useful. For this approach here, in the lateral aspect of the midbrain, a Transylvian half and half, sometimes through the tentorium. I like the Kawase approach for the upper pons, but not below 7th and 8th nerve. I love the supracerebellar infratentorial approach. It has 3 variants, as you know, midline, paramedian, and extreme lateral, if I want to approach the collicular plate. Sometimes the posterior interhemispheric transtentorial approach, if the lesion is too high, but I like to do it with the hemisphere down, not with a neutral position, so that you don't have to retract and you can do lumbar drain. Midline suboccipital telovelar, of course, excellent for the floor of the 4th ventricle. We, of course, should not forget the very useful retrosigmoid approach with all its variations, and I'll show you later a video of one variation. Sometimes, not very common, a more involved skull-base approach, such as the pre-sigmoid subtemporal retrolab approach, and very unusual for a cavernoma, most commonly used for an extensive petroclival meningioma. Far lateral approach is extremely useful for the pontomedullary junction. Again, I may have time to show you some case examples. So let's go over case examples. Let's start with, I won't have time to show you everything I want to show you, so I'll go quickly. Midbrain, rostral midbrain. I'll show you an example where I use the posterior interhemispheric supracollicular transpineal gland. This is a video. I am going, of course, to speed through it. This is the lesion. You can see it well. The question is, here is on coronal, here is on sagittal. What's the best approach? I thought this would be the best approach. Interhemispheric, transtentorial. I do the crani across the midline. I took a small bridging vein. There is no retraction, just a lumbar drain. Here I am marking the straight sinus to be able to cut the tentorium, which you can see right here. Once I cut the tentorium, I have a very good view of the vein of Rosenthal and vein of Galen. You can see them here. The key then is not to enter the superior colliculus, but here, right here is the pineal gland. Using navigation, it was clear that I should go through the pineal gland, and that gave me right there the hematoma cavity and the excellent view of the cavernoma without having to deal with the collicular, superior or inferior colliculi. And then I resected the cavernoma. The view was excellent. You can see the brain is in good shape. And here is a gross total resection at the end. Patient did beautifully. So I want to remind you the pineal gland can be a site of entry. Caudal midbrain. I want to show you a patient who was operated elsewhere, had failed a telovelar approach because that was not the correct approach, and came to me, and I did a supracerebellar infratentorial, the extreme lateral variant, and I'll show you that. I'm going to skip the history. Here is the original hemorrhage in this young patient. You can see there the cavernoma. You can also see that there is a DVA covering the cavernoma. So the other surgeon somehow went through the floor of the 4th ventricle, but could not remove the lesion because the DVA was in his way. You can see the DVA here. And he only did a small resection and left most of the lesion behind. The patient recovered well. 6 months later, she was referred to me with this lesion. So then, of course, the best approach, you can see a very nice view of the DVA. The best approach is really supracerebellar infratentorial. And you can see why with the yellow arrow. And I'll show you the view. Now, I don't use the sitting position for various reasons, not because I don't like it, but because of anesthetic issues, and we don't have the nice setup that, of course, Professor Sami has popularized. But the Concorde position is very good. This is what I did. This is a Concorde position. You can clearly see I have no self-retaining retractor. Concorde means the head and the trunk of the patient are elevated to try to get the benefits of a semi-sitting position. And it works fine for me. I have not really used the sitting position in a long time. But you can see the fourth nerve in the middle of the exposure. You can see the cavernoma, the superior cerebellar artery. And of course, it's very easy. Once you find it, the rest is easy. I'm working infratrochlear below the fourth nerve and coagulating into the cavernoma, not into the wall of the brain stem, of course, using Surgicel, piecemeal removal, sometimes like we do with acoustic neuromas, the Sami technique of traction, counter traction with a very fine forceps. And then and there you can see the wall of the resection, very clean after I'm finished. And I sometimes use an endoscope to assist and look to make sure I haven't missed anything. And here, when we're done, the cerebellum looks very good, even though we're in a Concorde position. And the view is excellent. And here is a resection, complete resection. Patient, again, did very well. I did give her a fourth nerve palsy that disappeared several weeks later. That's post-op, that's a DVA that was preserved. I'll show you an example of the rostral pons, a pregnant woman from Panama. I'll skip through the history. Look, they gave her steroids. They told her her lesion was inoperable. She became cushingoid and could not walk. She's in a wheelchair from steroids and from this lesion. You can see it here. The mistake would be to do this telovelar, even though the two-point method would tell you you should do it that way. That's wrong because you're going to give her a facial nerve palsy. So the better approach is simple subtemporal. And that's what I did. We monitored the fetus during surgery. Here is a fetal heartbeat and a simple approach for what is a formidable lesion. I removed it completely. And here she is post-op. Her third nerve palsy was unchanged. Her hemiparesis got better immediately. I believe I probably have time for one more example. So I'd like to finish perhaps with this one. The variations on the retrosigmoid approach are endless. So I want to again remind maybe the younger colleagues of presenting the case the petrosal fissure, or the so-called horizontal fissure is. Think of it as a Sylvian fissure of the posterior fossa and split it. So this is a lesion in a young woman who hemorrhaged. You could do, so I thought I'll do a retrosigmoid, but it was a little posterior and I needed to enter the middle cerebellar peduncle. The best way I found at surgery is to split that horizontal fissure. And I'm going to show you. So here is how I do the retrosigmoid. We get CSF at the near cisterna magna. Then we dissect, of course, no retraction needed. You can see 7 and 8. Now here is nice schematics of where we are. The next step, instead of retracting the cerebellum, is to split the horizontal cerebellar fissure. So you can see, I'm sorry, I skipped too quickly. You can see the superior petrosal vein. Here is the horizontal petrosal fissure. Here are the superior semilunar nodule and inferior semilunar nodule. You go between them. I'm reminding you where that is on a cadaveric specimen. And you see now that it is split. Look at the view of the fifth nerve exiting the pons. And now I can enter exactly. You can see where I'm entering right there at the middle cerebellar peduncle, right here. Unless you retract the cerebellum, you couldn't get this view if we had not split that fissure. And now the cavernoma is resected, and the rest is really easy. But again, here it is at the end, and there is a post-op, and there, you can see the tract of the entry. Splitting that fissure was very useful in doing that. Here she is post-op, doing perfectly well.
No.
I think I should stop because I think I'm over my time,
Yes, Professor Morcos.
Thank you very much.
No more time.
Exactly.
Thank you very much for this beautiful presentation.